Welcome everyone to my presentations on dental caries. My name's Professor Avijit Banerjee, and I have the great pleasure of working at King's College London Dental Institute at Guy's Hospital in London. You can see the image on the screen there is of Guy's Tower, the world's tallest dental hospital building, right next door to Europe's tallest residential building, which is the Shard of Glass. I've had the privilege of working there as a student and as staff for nearly 30 years and have spent my life's research and clinical interest in managing dental caries. This presentation is the first part of a double presentation looking at how we look after and manage caries in our patients. The objectives for this first presentation are to define the term MI Dentistry, because this is a terminology which is used a great deal across the profession, but sometimes incorrectly, and looking at minimum intervention oral health care as part of a contemporary patient-focused, team-delivered oral health care delivery approach. I'd like to discuss with you the different modes of the non-operative prevention of caries, as well as some of the very minimally invasive operative preventive approaches, and this will become clear as we go through the presentation. I'd also like to introduce to you the postgraduate training options that are available at King's, looking at a master's course that I put together in advanced MI dentistry. You will see QR codes on some of the slides, and these are there for you to scan using your phones, and these will take you to specific websites that are related to what is presented on the screen. So, why are you listening to this presentation? Why are you here? We're here as dentists and dental care professionals to help and prevent and manage this condition that we can see on the screen. I often ask the audience what's the most important word in the title, and the majority of the dental profession highlight the term prevent. Unfortunately, this is incorrect. The only person who can prevent the condition we're seeing there is the owner of that mouth. As oral healthcare professionals and as the team, we are there to help that person prevent this end situation of dental caries in such a severe fashion. Now, we can do this using advanced MI dentistry. And there are a couple of definitions on the screen that you can see, and these are really very important. We have the first, which is minimum intervention care. This is individualized, patient-focused care, where the patient takes responsibility for their actions, and they work with the oral healthcare team members in using the latest R&D in disease detection and diagnosis, susceptibility assessment, prevention control regimes, and minimally invasive operative treatments. You heard me use the term minimally invasive, and that's the second definition of MI dentistry, as you can see again, that's come up on the slide. And here we're talking about selective caries removal, moving away from the traditional approaches of treating caries as though it was gangrene and cutting it all away and then filling the hole with a predetermined material. We will talk about state-of-the-art operative technologies and material science in the second presentation. So we're really moving away from the dental surgeon's sort of mechanistic surgical approach to managing caries to a more physicians-based approach, where we're thinking about the biology and also the behavior management of the patient and the psychology. This is all very relevant because dental caries is still a major problem worldwide. The WHO have classified this as a non-communicable disease, an NCD, and in their global burden study that was published about 4 years ago, we can see in the rankings, dental caries came top. And this is something that's worth digesting. Over half the population of the planet suffer or have suffered from dental caries, so it's a real problem. It doesn't affect everybody equally, and there are socio-demographic issues to consider in different countries, but nevertheless, caries is still a real problem. If we look at the traditional approaches to caries management, we can see on the slide the process of how caries develops in a patient on a tooth surface. We have adhesion of bacteria in the biofilm and further colonization. We have demineralization and remineralization starting, which can then, if uncontrolled, lead to white spot enamel lesions and then dentine lesions, right the way through to tooth loss. And traditionally, many of us were taught to manage the condition at the top end of that spectrum when the damage has been done. This is a bit too late, because then we're not really treating the disease. Minimum intervention care actually starts to treat the root cause of the problem, and often that will involve behavior change for the patient. So the primary aims of the presentations, and in terms of caries management, are to start to assess the risk of patients getting the disease, or the susceptibility of patients for caries. Every human who has teeth is at risk of getting caries, but not all people are equally susceptible. So there is a subtle difference between the two terms. We also need to empower our patients, make them understand the value of oral health. Oral health is very much linked to systemic general health, and patients and the profession need to understand this and appreciate it. And that is happening more and more with government intervention around the world, but more and more work needs to be done on this. And therefore, the oral healthcare team must work together closely with the patient. And we have to do this sensibly, pragmatically. It's all well and good people like myself standing in front of you preaching on how to manage patients. But it's you guys at the coalface that are doing the day-to-day job with different human beings sitting in front of you with different problems. And therefore, the care plans you create with the patient have to be targeted to that patient, so they're achievable for that patient. So if you look at a framework for a minimum intervention care plan, there are 4 key aspects that are all interlinked. The first is identifying the problem the patient has. So different members of the team, and you can see on the screen there the acronym DCP, that's Dental Care Professional. So that could be a therapist, a hygienist, an oral health educated nurse, and so on. All members of the team gather information to find out what's wrong with the patient, to risk assess, and then to develop the care plan. A big part of that care plan will be prevention and control, and we'll talk more about that in detail in a moment. But again, the whole team, even including reception staff, everybody have to sing from the same hymn sheet. They have to say the same message. Many patients will approach you and your clinics where they have disease already present and cavities that are already present. And of course, we still have to operatively intervene. This is where minimally invasive dentistry comes in. And again, different members of the team can execute these actions, primarily the general dental practitioner. And arguably, the most important feature of the care plan is the last circle that's come up, which is the recall phase. I write a lot and write many textbooks, and therefore words to me are very, very important. And certainly in the UK, often the recall appointment is called a checkup. And that is a terrible term, because that implies to a patient that actually the appointment is not important. Therefore, the patient doesn't value it. And often they do not attend these appointments. This is a recall consultation, and as you will see a little bit later, is actually the whole glue that ties all these cogs together, where we review the treatment that we've provided, we review the behavior change of the patient, and using the patient, with the patient, we can develop long-term maintenance strategies. If we look in more detail in that, under that framework, we can start to see different sort of sectors that apply for each of those cogs, each of those circles. So in the identify section, you can see on the screen, we need to take histories, do an examination, use indices to measure and assess lesion presence, look at etiological factors, and all of those together will allow us to establish the caries susceptibility for that patient. From that, we develop a care plan. It isn't a treatment plan. A treatment plan to most of us is a list of procedures, an extraction, an endodontic treatment, fillings, gum treatment, etc., etc. That's a shopping list. We are caring for our patients, and the care will change. It will deviate as we progress. So a care plan is the correct terminology to use. And you can see that care plan in terms of caries management can be affected by the presence or absence of lesions, whether the lesions are active or not, etc., etc. You will note I've also highlighted caries susceptibility as being only high and low. And again, I will come back and explain why a little bit later on. But from this, we can start to develop a plan of action for patients who fit into some of these categories. I fully accept many patients will slightly miss some of these categories, but that doesn't really matter because this gives you a framework in your mind and in your team's mind of how to manage the disease condition. Under the restore cycle, we can see that there's more invasive treatment and less invasive treatment that is MI, minimally invasive, and we will talk about that in the second presentation. And as I've mentioned already, the recall consultation is absolutely critical to tie the whole package together. So if we look at some of these points in a little bit more detail. When I was at dental school 25 years ago, I was taught to take a sharp probe and stick it into teeth, into lesions. And we were taught that that was a nice way of detecting lesions, especially on the occlusal surfaces of posterior teeth. We know now, as you can see from the images on the top right, that by pushing a sharp probe into an early lesion, an enamel lesion, all we do is accelerate cavitation and make the situation worse. So it's imperative that any early detection any instrument you use for early detection should be ball-ended, should be rounded, so you don't actually gouge the tooth. There is damage, as we've mentioned, so please, if you're doing that, please stop. There are lots of other detection systems available on the market based on optical physics, fluorescence, reflectance, porosity changes, etc., etc. And these instruments are there, and they can be very useful if you understand how they work. They can give you a nice indication of whether lesions are present or not, and some objective recording for your notes, which is important for medical legal purposes. The only problem is these instruments are only as good as the dentist or the operator using them because they need interpretation. They are not perfect. And it's a very large topic which we do not really have time in this presentation to go into in any more detail. If we're looking at visual detection, we need indices to document what we're seeing. We live in a world where writing notes, reviewing patients and being able to monitor what we saw previously is so important. Therefore, a good quality index is critical. The International Caries Detection and Assessment System was developed approximately 13, 14 years ago and has undergone several iterations to allow a dentist to view the clinical mouth and the clinical situation and then relate that to the histology of the lesion as it spreads through the tooth. Many dentists found this a rather complex index to use on a day-to-day basis, but in terms of research and epidemiology, this index is being used more globally every single day. You can split the ICDAS scoring, as you can see on the screen, into sound, moderate caries, and then cavitated lesions. And about 10 years ago, when I had the privilege of taking over co-authoring the textbook you can see on the screen, I spoke to Professor Nigel Pitts and modified the score again into a 5-scale system, as you can see. And I'd like just to take a couple of minutes to walk you through this, because using this scoring system allows you to really look carefully and annotate your notes accurately. So as you can see, it's a 5-scale system, the modified ICDAS scoring, from 0 to 4. The 0 scale basically is a healthy tooth. So when you look at it, it looks healthy when it's wet, when it's dry, there's basically very little change on the enamel surface and everything is straightforward and sound. On a category 1 lesion, the wet tooth, the saliva-coated tooth, looks normal, but when you blow it dry, you start to see change. Something like I'm showing you on the screen here. We can see an upper molar, and if we zoom in into that central fissure, you can see the bubbles of saliva, and at this magnification, the tooth looks sound. If you blow the saliva away, you can start to see the frosty change, the enamel lesion there. And in this sort of situation, you know that that lesion is within enamel. It hasn't penetrated the enamel-dentine junction. And this can then help you decide exactly how you're going to manage this case in this individual, depending on their caries risk and other factors that you've ascertained. Category 2 is an interesting one, because now the wet tooth shows the change, but there is no actual clinical cavitation in the tooth. So this is still a non-cavitated lesion. But as you can see on the screen here, we still will have lesions that may have penetrated into dentine, into the outer third of dentine. When I was at dental school, if a lesion had penetrated into dentine, we were taught to pick up a drill and cut a hole. That is not necessary at the moment with our current understanding of the caries histopathology. And we will talk about that, as I said, in the second part of the two-part series. So you would now have to make a decision as to whether you want to intervene or not, and that's a clinical decision that we will discuss. Categories 3 and 4 gets easier because now the lesions are more extensive. We've got cavitation, category 3 a small hole, category 4 a deep, bigger hole, and of course you're going to start to restore these teeth. So as you can see from this 5-point scale, at either end it's quite simple. It's the category 1 and category 2 that needs a little bit more care. And if you're wearing optical dental loupes, then this sort of thing becomes much easier. And I would strongly advise all of you to be using loupes with good lighting to allow you to see all these changes. So that index is all about caries detection. One of the things perhaps at Chairside professionally we're not so good at is looking at the activity of lesions. So here you can see 2 proximal lesions on upper incisors, and the image on the left on the screen is the classic image of an arrested lesion, and we can see that highlighted here, where you've got that brown stain with that sort of shiny appearance, the gingiva are stippled, there's no plaque, and we make the assumption that that lesion is arrested. On the right, we can see a cavitated lesion with plaque. We've got an inflamed gingiva, the stippling is going, we've got a plaque biofilm here, and again, we make the assumption that that is an active lesion. But we, at the moment, do not have anything clinically to help us delineate the two, although things may change in the future. We use radiographs to help detect lesions, and as you know, when you take a radiograph, you must write a radiographic report. That is a legal, ethical, moral requirement. And there are indices for you to analyze the radiographic appearance of the X-rays that you've taken. And that you can see on this table. You can divide the enamel lesion radiographically into outer and inner half, and you can divide the dentine lesion and the radiolucency into thirds or halves. You can also see how the modified IC-DAS scale also links very nicely with the two. And the beauty is you can write these codes, and with digital radiographs, you can actually annotate the radiographs directly now. And this is really quite useful. So, if you look carefully at the radiograph on the screen, I wonder if you can spot a couple of D1 lesions. I will help you out, and we can see that there are lesions there on the premolars. This was a clinical case where these lesions were deemed to be non-cavitated at the time of presentation, and non-operative prevention was instigated with dietary change, oral hygiene, flossing, etc., etc. The patient was informed, and all of this was documented in the notes. The patient was asked to come back for recall after 3 months, and unfortunately they did not attend the appointment. And as you can see, as the radiograph changes, 11 months later, we now have a problem because the lesions have increased in size. And this is where we have the medico-legal conundrum of MI dentistry. Who's responsible for this? Well, ultimately, it is actually the patient's responsibility to look after their teeth. But the oral healthcare team also has responsibility to work with that patient. And this shows you why that interaction, as I was mentioning earlier in the definitions, is so important. When we're looking at the identify section, we've mentioned some of these points, and all together we look at the etiological factors to help us decide what the susceptibility is for that patient. There are many challenges facing us in modern caries management. The care planning is actually multidisciplinary. We need long-term review and maintenance, and we have got new techniques and materials that are available to us. And if you tie this all together, you can see all the different factors that are involved in reducing caries incidence. The diet, fluoride, saliva, the patient motivation adherence, clever chemistries to remineralize tooth surface, and biofilm plaque control. If I highlight saliva, something that perhaps is slightly overlooked by many patients in terms of caries management. In the profession, we all know how important saliva is, but do our patients know? We can see on the screen all the different components of saliva that play a part in controlling disease process in the mouth. Without it, as we know, patients with xerostomia, dry mouth, are often at much higher risk of getting carious lesions. So we need to look at saliva, and you have to be honest with yourself and ask yourself, do you actually analyze patient saliva? And if you do, how often do you do it? There are little tests you can do. Invert the lower lip of the patient, place some gauze, and get if the minor salivary glands are working, you will see the little dots, as you can see in the top right image in that cluster, form within a few seconds. If the minor salivary glands are working, then the likelihood is the major glands will be working. We can look at the quality of the saliva, the viscosity, the description, clear saliva, bubbly saliva, sticky saliva. And from the history, medical history, verbal history, that you and your team will take from the patient, you will start to pick out any other factors that might trigger dry mouth. Be aware, in the UK, nearly 1 in 5 patients have altered saliva. Not necessarily full dry mouth, but they have altered saliva. That's 20% of the population. So the changes in saliva are really critical in the etiology of caries. This is a QR code that will take you to the site where you can download this index. So this is a clinical index measuring oral dryness. And Professor Stephen Chalicum, who worked at Guy's and at King's, who's now retired, has put his name to this. And this is a very elegant, simple index that can be used that looks at 10 clinical signs and symptoms. And if a patient has any 3 out of those 10, they're mild. If they have any 6, they're moderate. And any more, you should be considering referral to have the saliva analyzed in case there's a more systemic reason for their dry mouth. So please do print this off, put it in your surgery. You don't have to learn it, but you can use it. And again, you can write down your finding in your notes. So medico-legally, it shows you have actually examined the saliva. There are other chairside tests that can be used to look at the saliva. You can look at pH and buffering capacities. We know the critical pH for mature teeth is around 5.5, and for younger teeth around 6. I am not saying that these tests on their own will tell you whether the patient's more at risk or less at risk. But from a behavioral change point of view, when a person can see that there are alterations, that has much more impact than just being told. So a lot of these tests, even though on their own may not be of massive benefit, collectively can help change the patient's perception of their own problem. When we're looking at plaque control, we need proper brushing technique. There is some evidence now to show rotating, oscillating electric brushes perhaps are more effective at removing plaque biofilm. We need to think about brushing frequency, classically twice a day for about 2 minutes. Studies have shown most people only actually brush their teeth for around 30 to 40 seconds at a time, but they need to be managing to clean properly for at least 2 minutes twice a day. We need to look at interdental cleaning, the types of toothpaste and the amount of toothpaste, and the fact, of course, that you do not rinse your mouth after you've brushed your teeth. You just spit the excess out. There are indicator kits that are available, again, which can help the behavior management of your patient. It's this tri-plaque gel indicator, which is a very neat system to allow a patient to very graphically see the problems in their mouth. You can see there are 3 colors, and the pale blue color is actually highlighting where the acidic change is appearing in that mouth. There's a greater lactic acid buildup at the cervical margins of those lower teeth. That doesn't mean this patient is going to get caries there, but they are more susceptible. And that graphic image, again, can have a big part to play in the behavior management for that patient. So it will show up quantities, the age, the density, and the acidity. And it's a powerful motivational tool. And it's something a patient could even do at home. And if they engage in their oral health care, their caries incidence will drop. So we want to tie all this together to get your diagnosis and your prognosis and establishing that susceptibility. We're all aware, I'm sure, of caries risk assessment strategies using a traffic light system, red, amber, and green. High-risk patients where they've got greater than 2 new or progressing or filled lesions in the last 2 years, or more than 1 active lesion, they are classified as high risk, and then you can see the definitions for medium and low. If you noted earlier on one of the slides, I mentioned that caries susceptibility could be kept as high and low. That's from the profession's point of view. We manage the high-risk and medium-risk patients together. And I think it's important, and I would like more and more dentists and oral healthcare team members to really take risk assessment seriously, because you can then target your care appropriately for those patients that you treat in practice. If we look at the control of caries, again, the control of high and medium risk patients is similar. It's going to be targeted to the individual. It's going to include dietary modifications, behavior change in oral hygiene. You may supplement with fluoride, etc., etc. And the low-risk patients undergo a continuous maintenance program. From a patient's perspective, perhaps we should have 50 or 100 levels of risk. And a calibrated practice can then start to move patients up and down a league table, if you like. And if you've got a family, you can actually start to get competition of changing behavior. And that, in the modern era, is something that might help trigger and motivate people to look after their mouths and oral health. So using all these indices, we can then start to develop tables to allow us to build a picture about the individual's risk assessment and susceptibility assessment. This table is one such example that was published in my textbook that I showed you earlier, and it picks out some of the key indicators for caries susceptibility. There are over 130 different factors that affect caries susceptibility, and there is no way you can ask every one of your patients all those different factors. So what you need to do for the patients you care for is tailor your risk assessment accordingly. Pick out some of the key features and highlight whether the answer is yes or no. And by doing that, you can start to work out reasonably accurately what their ultimate risk assessment is. Now, I apologize, the next slide is a little bit busy, but I'd like to walk you through it if I may. If you remember the 4 cogs of a minimum intervention care plan, we can look at the identify section and see how we can divide patients up into those who have lesions or not, whether they're cavitated or not, their modified ICDAS score, and their risk. And according to that, we can start to categorize them in terms of their prevention and control regimes. And I will go into this in more detail in a moment. Those who are presenting with lesions, we can then manage using different materials ranging from sealants to glass ionomers to resin composites, etc. And as I mentioned earlier, the recall strategy is really quite critical, and again, I will highlight this shortly. So in looking at the prevention and control, again, two very important terms. You can't prevent the caries process, but you can control it. You can prevent lesions. And this is really quite important, so I'll repeat that. You can prevent the lesions from developing, but you control the process, and you do that with the patient using different approaches. So we have standard care or active enhanced care. So for patients with a low risk, with no lesions, these patients can be monitored and maintained over long periods of time. And you can do and give advice to these patients so they actually practice their prevention at home. So the patient administers it, but the oral health care team instructs and advises. And it covers toothbrushing, toothpaste, flossing, diet advice, patient motivation, and other maintenance therapies. It throws up an interesting point that these patients, who are the majority, which is good to know, don't necessarily need to see a dentist every 6 months. They do need to see a member of the oral health care team, and that may be over 12 months or even 18 months. And in terms of workforce development around the world, this is something that bodies need to take into account. If we look at the higher risk patients with lesions, then we move on to active or enhanced care. So this includes all the things we've mentioned in the standard care, but we're adding to. And these are things that the oral health care team will actually also deliver in the clinic, at Chairside. So we can look at decontamination, at remineralization techniques, possibly treatment of etiological factors, although that may be out with our remit as dental care professionals, and we can start to then look at sealants. And I'd like to go through some of these again in a little bit more detail. So we've all aware of Jo Frenken and his excellent work he did with the atraumatic restorative technique and treatment, and that is a very useful concept to use when managing gross caries, as we can see in this patient here. This is a young patient in his early 20s who had methadone-induced caries and was obviously graphically suffering from gross, sort of rampant disease all around the mouth. So to manage this patient, to cut a long story short, we managed him operatively, of course, to try to restore these teeth. And the reasons for restoring these teeth over time were to allow him to have better oral hygiene control and biofilm control. And again, we will perhaps talk about this case in the second presentation in a bit more detail. So that's decontamination. We can also look at remineralization techniques, and it's important to understand what's happening in terms of the physiology of demin and remin in the oral cavity. So here we have the Stefan curve, which we're all aware of, an excellent piece of work done by Stefan in 1940 to show the changes in pH and plaque after sugar intake. And we all understand how the pH drops very dramatically and then gradually picks up again as the saliva helps to buffer and control that pH. The critical pH of enamel, we're aware, is around 5.5. For dentine, it's around 6.2. This is relevant because more and more of our patients have lost enamel through tooth wear and therefore have exposed dentine in the mouth. And that dentine doesn't necessarily need as much acid to demineralize it. A common misconception amongst most of the oral healthcare profession is that they remember these figures from the textbooks and we write them down in exam answers, but we forget that these numbers can change depending on the oral environment. So, in a patient who's got good quality saliva with lots of calcium and phosphate in the mouth, actually those patients will require more acid to cause demineralization of the enamel and dentine. In a patient who has altered saliva with less calcium and phosphate in the immediate environment, they will need less acid to cause demin. And this is really important when we're trying to find the etiological factors that cause caries in these patients. So it's something worth remembering, really very important. And where do calcium and phosphate, the building bricks for remineralization, come from? Well, as I've mentioned, they come from saliva. So for 80% of the UK population, there's no problem because they have decent saliva. But for the 20% of the population, we may need to add the relevant building blocks. And how can we do this? Well, there are solid calcium phosphate systems with phosphosilicate glasses and functionalized TCP, which is the basis of the 3M products, hydroxyapatites. We have also got the unstable calcium phosphate systems, the amorphous calcium phosphates and the casein phosphopeptide amorphous calcium phosphate derivative from the GC tooth mousse products. So the 3M product is a Clindpro white varnish, and this is a varnish which contains fluoride and the beta TCP technology. There's lots of research evidence to show how this material can help with dentine hypersensitivity and allowing some sort of remineralization to occur, especially on dentine surfaces in terms of filling in tubules. The product, which is tooth mousse or MI Paste Plus in the UK, uses a different type of technology to bind the amorphous calcium phosphate to the tooth surface using a phosphopeptide molecule. All of these products help to remineralize tooth surfaces quite effectively in high susceptibility patients. In terms of sealants and surface protection, if one looks at all the literature, it is clear that resin-based sealants in patients where the dentist or the operator can get good moisture control using rubber dam, the resin-based sealants are the best sealants to use. They show the best results in terms of preventing caries in those teeth with the sealants. But it is all dependent upon the clinical operator and their skill of placing a sealant, and also the patient in terms of their skill of actually brushing their teeth. I hear too many times dentists complaining about the fact that fissure sealants don't work and that they leak, and then they get caries under those sealants. But evidence has shown that usually it is the actual operator technique that is at fault rather than the material itself. There are also glass ionomer-based fissure sealants that can be used for patients where moisture control is more complex. For example, young children with erupting molars. The 3M product is another Clindpro sealant, and again, this is a resin-based system with some fluoride release capability. And we can see that being used here, and as I walk you through very quickly some of the steps. It's important, actually, that the occlusion is assessed even before placing rubber dam, because any excess material that overlies any occlusal contact will fracture on occlusion and potentially cause leakage problems under the sealant. Once that's done, the isolation is put on, and then the enamel surface and the fissure pattern should be thoroughly cleaned and debrided using cups and brushes and polishing pastes. The surface then should be etched carefully and rinsed and dried off. The sealant placed very carefully and flowed into the relevant areas with not too much excess, and then light cured. After which the rubber dam is removed and the occlusion is checked to make sure that fissure sealant isn't actually impinging on any occlusal contact. If we look at smooth surfaces, we have an interesting problem to deal with, and this is a nice clinical case that's been portrayed by Lewis Mackenzie, a colleague of mine in the UK. A patient he was treating for many, many years, reviewing these lesions in the lower right quadrant, so the lower right canine and first premolar. We can see the lesions after 11 years, and we start to see that there may be a problem brewing. If I zoom in on these, we have two lesions. This one, I think we'd all accept with its clinical appearance, is arrested, and the tooth next door, we've got this matte appearance, which indicates possible activity. One has to then work out why has that lesion become active. And the likelihood is because of this little lip of enamel that's around the edge that is actually trapping biofilm. and the biofilm has stagnated and has reactivated the lesion. So the management, sensibly, will be just to modify that lesion, remove that little lip of enamel by using a composite finishing burr just to polish it off. You can hit that lesion with some remineralizing paste, and then you can see with reinforced oral hygiene, over a period of weeks, the lesion changes from the active appearance on the left to the inactive appearance on the right. Many dentists would consider excavating the caries and placing a restoration here. That is actually quite a difficult restorative procedure to carry out, to ensure the right amount of tissue is retained, to ensure moisture control, to ensure adequate bonding and aesthetics. And I see many, many cases of restorations placed in these situations which are poor. They leave margins that overhang and actually accentuate the problem rather than help. Another situation presents with patients often under dentures that they're wearing. And here we can see a really nasty case of caries at the cervical margins on the lingual aspect of these lower anterior teeth. And think to yourself, how easy are those restorations to restore? And I would argue they are probably some of the hardest restorations for a dentist or an operator to try to physically restore with restorations. So is there another way of managing this? Again, it all goes back to getting the patient to understand what the problem is and getting to the cause. And the cause is oral hygiene. So train the patient with optimal oral hygiene, and in this case, proximal oral hygiene. Again, saucerize the lesions, make them more cleansable, remove the overhangs, the plaque traps, the biofilm traps. But we're not excavating caries. We're not drilling the teeth in terms of the classic sense. And by doing that, you can convert that patient back to an arrested situation, which is completely controllable and manageable. So in summary, non-cavitated lesions really must be tackled non-operatively first. The instrument of use should be a toothbrush that the patient uses, and all the other things I've mentioned on the screen there. If a lesion is non-cavitated, please do not pick up a drill. This is a very, very critical point. If we look at the recall consultations, we need, as I mentioned earlier, to think about the purpose of them. They are not checkups. They are much more important than that, and that needs to be emphasized to the patients. We need to review the status of the treatments that we have provided in the last episode of care. We need to reassess carefully the changes in patients' behavior, in their attitude, in their adherence to the advice you've given. Are they actually doing what you have asked them to do? If not, you and your team have to work again with the patient to get that message across. It can be difficult, but it's not impossible. And I accept there are many situations around the world where the healthcare systems may not always allow us or remunerate us to do this effectively. And the other aspect is to get the patient to be involved in their own recall strategy. I work in private practice and I do minimally invasive periodontology. And at the end of my episodes of care, I get my patients to work out when they next need to see me. And more often than not, they actually get it about right. And I have a very low failing to attend rate because the patients are engaged and therefore they come back. And that recall cycle then allows us to go through all the minimum intervention care plan COGS and keep everything nice and healthy. These are guidelines for recall strategies. They're not fixed in stone and they can be adapted and changed. But these are guidelines that should be followed. So a low-risk patient with no lesions doesn't necessarily need to be seen every 6 or 12 months. You might extend that period. You might use another member of the oral healthcare team to review that patient. You might phone that patient or use social media to contact that patient to check they are happy and everything is ticking along. On the other side of the coin, we may have very high risk, high susceptibility patients that we may need to see every 6 to 8 weeks to begin with, and then modify the intervals accordingly. What is critical is that the patient understands why this is being done and that it's written in the notes. Those are the two very critical things. So in summary, we've got to think about communication and documentation in this minimum intervention oral healthcare approach. It is vital we take patients along with us when we make decisions. The days of the dentist telling patients what to do, those days are gone. We have to engage with the patient and let them help evolve their care. When we take any special investigations, we must write reports. Again, the days of taking radiographs and then putting them in the notes are gone. We have to write reports, and with digital radiographs we can actually annotate the radiographs directly, and that can be very beneficial to allow us to review situations. It is absolutely vital that we justify every decision we make, whether it's non-operative or operative, whether you're going to do something or you're not going to do something. And you have to justify them to actually 3 people, that's all. You need to justify your decisions to the person you're talking to in the dental chair. You have to justify the decisions to the person you see in the mirror every day. And if you justify it to those 2 people, you don't have to worry about the 3rd person who might be a judge one day. So do justify. Write good quality contemporaneous notes. Many of us are using electronic patient record systems. They can be of benefit, but you need to watch out and be careful that you're not copying and pasting text. Each set of notes has to be individual to that patient. But if you're using more and more indices, like some of those I mentioned earlier, the coding will be enough. You don't have to write a full verbal description if you put those codes in, because those codes will tell any reader of your notes that you've looked for the problem, you've detected, you've diagnosed, you've processed the problem, and then you've actually made a clinical decision, all from writing those simple codes. Personally, I think clinical photography is a must because they will help you engage your patient, motivate them, and allow you to have long-term review of your patients. And it's a skill that really must be taken on board. I'd like to show you this video for a moment, and I will then explain shortly. Minimum intervention oral health care is a contemporary approach to managing oral disease, and in this case specifically dental caries, and maintaining oral health in our patients. We're using the full oral healthcare team to deliver this approach, and it is very much patient-focused, working on the relationship with the patient to get them to understand their disease condition and how to manage it and prevent it. I have been fortunate enough to gain the expertise from 10 different national and international experts in the field of MI dentistry who produced papers for this issue. These are all useful for every member of the dental team and will cover topics ranging from risk assessment and patient behavior management through to remineralization technologies for early lesions, selective caries removal protocols and minimally invasive techniques to do this, managing the child and older patient in an MI way, and also developing your business practice and also the medical legal aspects. I hope you find this issue interesting, and thank you for listening. I had the privilege to edit this edition of British Dental Journal in August 2017, and the papers in it will actually back up and provide evidence to all the things that we've talked about in this webinar. The QR code is there that can take you straight to the relevant web page. As I mentioned at the beginning, one of the final objectives of this presentation was to highlight some of the postgraduate dental education that's available in minimum intervention dentistry. And I developed a distance learning master's program at King's College London about 5 or 6 years ago, which is the only one of its kind globally. This is open to all practicing dentists and therapists around the world. And what it will do is highlight how MI oral health care is a real paradigm shift in the way we're offering care to our patients, moving away from the traditional operative mechanistic approaches towards the care-driven biological process with the patient. We will teach all the latest cutting-edge diagnostic, preventive and surgical skill sets, And we will teach also about workforce development and business planning for your practices, depending on where you work around the world. There is a sustainable and profitable business model behind MI Dentistry. And again, this is something that we bring out as opposed to just the clinical dentistry. And it's critical that in the profession that is very difficult and very tough, that we actually enjoy our work and enjoy working with patients. So if you're interested, please, again, scan some of the QR codes you can see on the screen or follow the instructions, and I can give you more information about the programs. What follows is a little short video testimonial about my master's program.
Minimal intervention dentistry is about treating the whole person, interacting with the individual and building a real relationship so that they maintain oral and dental health throughout their lifetime. That's the reason why I chose AMID at King's.
So with that, I'd like to thank you all very much for taking the time to listening to my presentation, and hopefully I'll be speaking to you again in the second part of this series in the MI management of dental caries. Thank you.